Hello and welcome to Cardia, Hearts and Sciences, the program dedicated to the understanding of the human heart. I'm Mark McDonald and very fortunate to have a host who is very good at heart issues and also medical issues. Our Dean of the School of Hearts and Sciences, Dr. Greg Mishkel, who's also the Executive Medical Director at the Prairie Heart Institute. Dr. Mishkel, thank you very much.
Co-host.
Co-host, that's
Not
right.
host.
That's right. In fact, I should have you introducing me, I guess. But that's terrific. And also, you also get a chance to bring some of your colleagues in from HSHS St. John's once in a great while. And we're really glad to have Dr. Michelle Alepra here, who's the medical director of the emergency department, if I got that right.
Yes, sir.
Okay. Dr. Alepra, since this program deals mostly with heart issues, let's start off with how a person that seems to present with heart issues to the ER, how do you sort out whether they need heart treatment or some other kind of treatment?
Well, we start obviously by seeing the patient, and within the first 10 minutes of someone arriving to the emergency room and having chest pain, they receive an EKG within that first 10 minutes, preferably within the first 5 minutes of coming to the emergency room. With that EKG, it tells us if they're having a heart attack right at that moment and need to go straight to the Catheterization Lab where they would meet Dr. Mishkel or one of his partners. If they aren't having any signs of a heart attack right then and there, then we start by medically treating them with known cardiac prevention like aspirin. We give them nitroglycerin if they're still having chest pain, and then we do medical workup in the emergency department, which includes blood work and a chest x-ray.
But how do you, like if somebody seems to be presenting with some kind of an emergency, how do you move them up in the queue? How do you get them attention right away?
Yeah, how do they get your attention? Are there code words that if they mention I'm having this?
Yes, if they come into the emergency department complaining of chest pain or shortness of breath or anything that could be a possible heart attack or heart attack related symptoms, we do what's called a call A, which means they overhead it over the entire emergency department. Everyone in the emergency department knows where that patient's going. They'll say call A to room whatever, room D, and so we know that they're there. They come straight back within immediately from triage. They don't even register them out front. They just bring them straight back.
And that brings up another interesting question, because some people will present with what might seem to be stroke symptoms. And do they get the same kind of treatment? Really?
Yes, sir.
Is that code? What is that?
Code S.
Code S.
Yep.
Okay.
It's a call S.
Call S.
So I think one of the important things that Shelley mentioned here is that first of all, what she's describing is a triage system. So patients get triaged in terms of their symptoms and a priority. And then the other thing is when we discover that somebody has a true emergency, whether it's a stroke or a heart attack or there may be other issues, we don't sit around taking their insurance forms, and they get moved right ahead of everybody else.
Now, I know at Prairie Heart Institute you have a method that not every hospital has. You have a way to get people to the cath lab right away instead of having them go through a series of tests before they get taken to the cath lab. How does it work?
Well, if we can identify that somebody's having a heart attack, for instance, the ambulances now have the ability to do EKGs at somebody's home or in the field, and those EKGs are transmitted to us, and if they're correctly interpreted, we look at it, Shelley looks at it, the emergency room docs look at it, and they go, yes, in fact, somebody's having a heart attack, and we have staff at the Heart Institute. We won't even have that patient come into the emergency room. They'll bypass the emergency room and come directly up through a back elevator to the Heart Institute.
No kidding.
Yeah.
So there in the cath, and for those who don't know, the Catheterization Lab is where you can actually do internal heart checks to see if the blood is circulating properly, right? Rather than have to take pictures and all that kind of thing, you can actually get right in there and find out.
And one of the things that we're working on is a system within Springfield, because this system works great if you're out 20, 30 minutes outside, but what we're going to be working on is a system within Springfield where the paramedics can identify patients maybe in their house, and if appropriate, we may do the same thing, bring them directly to the cath lab without going and stopping in the emergency room.
So they can make the diagnosis from the field. They don't have to wait until they get there.
Correct.
Wow. Okay. That's in heart is muscle, right? Or time is muscle?
Time is muscle.
Time
Very
is
good.
muscle. Okay. So if I'm having a heart attack, Dr. Alepra, if I'm having a heart attack and I can shave 2 or 3 minutes off that time before I get it opened up, it makes a difference, doesn't it?
Absolutely. And as Dr. Mishkel was saying, we've partnered wonderfully with the local paramedics and with Prairie Heart Institute, that even if it's not during hours where the cath lab is currently staffed, even if they take that EKG in their home and send it to us, we can activate the cath lab and Dr. Mishkel and his partners from home before, if it's 2 in the morning, we can let them know before that patient even gets there that that patient is coming. And so every minute it shaves off 5-10 minutes of time, and so it does make a huge difference.
And I think that you all must be kind of special, because you must be the kind of people that love to rise to an occasion where you're needed, because it's 24/7, and people are coming in there in all kinds of situations. So you're ready for anything all the time.
Yes. Yep.
Is that a special type of person?
I don't know if it's a special type of person. You have to be willing to, you have to enjoy seeing anything that walks through the door, and it can be anything from a heart attack to a trauma to, gunshot wounds to respiratory problems to strokes to anything, and you just have to be ready for whatever walks in. ER people like variety, and we like to be ready.
Be
and
surprised when you get to work.
Yes.
Let's take a look at clip 1 while we talk, because this is you giving us a tour of the St. John's ER. I'm sorry, Greg, go ahead.
Yeah. Well, I think one of the biggest challenges, and Shelley, maybe you can address this, is sometimes it's not an emergency, and sometimes it's an emergency and the patient doesn't think it's an emergency. How do you differentiate the patient who has a cold versus the patient who's maybe more seriously ill?
And as you discussed, we do have a triage system, obviously. And so every time someone comes in, they're immediately seen, they talk to a nurse, they're immediately seen. The nurse is trained to ask them specific questions that help kind of cue us into just that, to the emergency situations and the more critical or higher acuity situations. And they give vital signs, so those are another thing that can kind of cue us into something being wrong. Fevers, increased heart rate, low oxygen levels. With kids, we're in the middle of really high respiratory season with young children in pediatrics. And so just that, how fast are they breathing? How much distress do they appear in? And so similar to what we were talking about with strokes and heart attacks, we have respiratory calls where if someone's in respiratory distress, they come straight back. So there's always that triage system to help us do that. And then once we see the patient as well, we help determine, with a series of questions, just how, could it be a more acute situation, or is it something that's less emergent?
Yeah. But staffing must be the devil, because you never know. Now, you were saying before you sat down here that this last weekend was extremely busy. And so you got to be staffed for it to be busy even when it's not. How do you do that?
Well, we staff the same every day, and some days it's slower than others, but we're generally staffed for being busy, and on most days we are busy. We generally are full by mid-morning and stay full until late evening, until about midnight, and so we staff accordingly to that. And over the years, we kind of know what our time frames are and our ebbs and flows, and when we need to be higher staffed and lower staffed. But there's always those times that it's really busy at 4 a.m. and you know that's part of being in the emergency room, is that we also know that there are times that there's going to be a lot of people and there's only so many of us, and we still manage to see everybody.
Do you have people on call then for those busy times? You don't. You just handle it. You're staffed to handle it, and what comes in you're going to take. And it's not like you call the rest of the hospital and say, hey, get on over.
Right.
It doesn't happen that way, huh?
Not unless there's a major disaster.
So how many people do you have, how many physicians would be working, say, with physician extenders during the daytime versus at 4 in the morning?
There's always at least 2 physicians, or physician and physician extender there. We go down to 1 physician and 1 physician extender between 3 in the morning until about 6 in the morning. But throughout the rest of the day, we have at least 2 physicians. And the vast majority of the day, we actually have 3 or 4, because we're staffed with a pediatric provider now every day of the week except for Sunday, which will also be changed starting in July to 7 days a week. So throughout the day as well, we have multiple providers plus mid-levels, and now we've also added a pediatrician every day.
And excuse me, Greg, let's take a look at clip 2, because we'll get a chance to see what some of your nurses, what charge nurses and pharmacists, et cetera, do. But anyway, go ahead with your question. And
I suspect that trauma has also added a fair bit of complexity to staffing.
Yes. We're staffed the same every day for traumas. There's always a trauma attending in-house 24/7. And so there's always that extra physician that does do specifically trauma within the hospital. During the day, there's multiple of them there, and so they can always have other people come down as well. But our nursing staff are TNS certified, which means that they are trained specifically to do trauma. They're trauma nurse specialists, and so we have a specific number of trauma nurse specialists there 24/7 as well. So when traumas come in, there's the trauma attending, there's the ER attending. We have our mid-level extenders if needed for a trauma as well, but then we have specific trauma nurse specialists that are certified for that.
In addition to that, you have a pharmacist on duty, and I think you said all the time.
Yes.
Is there always a pharmacist
Yes,
there?
24/7.
Okay, now what is the job of that person?
Well, they have a lot of jobs in the emergency room, actually, but their main job that they do every day is that they're verifying all the medications that we give. So anytime I order a medication, there's a misconception that the physician goes and grabs the medicine and gets it for the patient. We have a lot of checks and balances. I order a prescription or order a medicine, the pharmacist then verifies it, then the nurse is the third step, actually gets the medication and administers it to the patient. So there's a lot of checks and balances, but they check things like dosing for weight for pediatrics, they check allergies, they check dosing for kidney clearance and things like that to make sure everything is right in the appropriate dosing. So it's another check from when the physician orders it to actually getting administered to the patient. That's their main job, but then they obviously help us when it comes to choices of medications, especially antibiotics. With all the different measures and CMS measures and everything else, there's different specifications for things like pneumonia, depending on if you've been in the hospital recently or haven't been in the hospital or in a nursing home. So they help us keep up with those guidelines and make the best antibiotic choices, because obviously that's what their specialty is and what they help us with. When we run any kind of code or an arrest, they're there with us, helping us with getting the medications ready, giving it to the nurses, reminding us of what's up next, just being an extra hand within emergent situations or arrests. And they're also in each trauma. So they come into each trauma, they help give medications in the trauma. They actually, sometimes they'll help the nurses, they'll help the physicians, they kind of help everybody in the room, and they're another part of our team.
Does anybody keep track? I'm sure somebody does. Maybe you don't know off the top of your head, but how many patients you would see in a given time, in a month or a year? Or?
Well, on average, we see about 160 to 170 patients per day.
Oh my goodness!
And that's on average.
Oh my goodness, that's a small town.
And
it's a village.
Yeah, and then basically over the past few months, we've been seeing even more than that. We've had a really high census over the past few months. We'll drop as low as 150 to 140 on very slow days, and obviously on really busy days, we'll see 200.
And the intake must be, I would find that to be very interesting, because somebody at intake has to be able to determine right off the bat, there's where the triage trick comes,
Right.
Somebody at intake has to be very skilled, don't they?
Yes. Yep. We are blessed to have a very, very good nursing staff in the emergency department. They're all well trained. No one can go out to triage until they've been a nurse in the emergency department for a certain period of time. And so someone who walks in off the street and it's their first day they're nursing, they can't go to triage. Our more experienced nurses are out in triage that have worked down there and have had experience over time in the emergency department. And so those are the ones out front. And they take everybody in very quickly, and they know who they need to get back quickly and who they can wait a minute to get vital signs and further evaluation.
And I find this issue that you have a pediatrician on staff around the clock?
No, well, right now it's for 9 hours a day, 6 days a week. We just are expanding that coverage. We've just hired another pediatric emergency medicine, so another physician who specializes in not just pediatrics, but pediatric emergency medicine. So she'll be starting in July. We already have another full-time pediatric emergency medicine trained physician, and then another pediatrician who does only ER, along with some folks that are peds EM trained that kind of do a few shifts here and there for us. But we have 3 full-time people now who do pediatrics every day.
Because remember, the children's hospital is a big emphasis at St. John's, so we want to make sure that we're not only ready for hearts, but ready for kids.
Yeah.
Yep. And one thing, though, that we've done new since the beginning of the year, the end of 2015, is that was new to our community for St. John's, is because we've added that extra provider in back. We wanted to be able to see more people since we had an extra provider. So some of our low acuity patients, instead of making them wait for a long period of time for all these more acute patients to be seen, they're actually able to be seen in the waiting room by one of our mid-level providers, one of our physician assistants or nurse practitioners. So if they're a lower acuity, instead of having to wait to get a room, now we're allowing them to be seen up front, get their care that they need, and be able to go home without having to wait for 3 or 4 hours on those busy days.
Well, Dr. Alepra, thank you so much. What you've done has made us curious about this trauma. So we've arranged to have a trauma surgeon come in and follow you. So thank you very much for spending your time with us.
Thank you very much, and thank you for having me.
And we will be right back. Welcome back. We're welcoming Dr. Cardia-Always, who's the trauma surgeon, the
medical director,
the trauma medical director at HSHS,
and a trauma surgeon,
at at St. John's Hospital. And we were going to cover all kinds of topics, but we settled on her day today because she came in and said she had the busiest trauma day she's had in a long time. So what exactly does a trauma surgeon do on a busy trauma day?
And what does busy mean?
I tell you what, I thought I was busy today, but I'm not sure I want to hear this. Yeah.
She is in a nice white coat, so at least she cleaned up before she came in.
I tried.
What is a busy day? What's it like?
So for us, a busy day is anywhere between 3 very sick trauma patients that take up a fair bit of time, up to 10, 12, 15 trauma activations where patients have had anything from a gunshot wound or a stab wound to something like a bad car accident to even just a ground level fall or a fall downstairs. And so those patients require the attention of a full trauma team, and when you get those back to back to back with less than an hour between them, it tends to get hectic.
And how many today?
We've had, 6 or 7 so far this morning. And this isn't even dinner time yet. So
wow, we'd better get you back to work. We won't keep you long, but it is interesting because when we were there on a couple of days, actually 3 days in December, and very little activity. You know, and you have these operating rooms that are set aside just for trauma. That's what they're set for. Sometimes they get used, sometimes they don't. Sometimes your staff is busy. Sometimes how do you staff for that?
So we have an operating room available to us at all times. That it is very feast or famine, to touch on what you said previously.
In fact, let's look at that clip now while we're talking about it. I'm sorry, go ahead, doctor.
Oh no, so we have a CAT scanner that's up and ready for us. That's what you're seeing. We have an interventional radiologist and his full team that's always prepared if we need his assistance. And then we have operating room nurses and anesthesiologists who are ready for us anytime, 24/7. So anytime a patient comes in and needs to go to the operating room, we have all of the capabilities ready and waiting to go immediately to the operating room under emergent circumstances if the need arises.
And this is your trauma room, and it looks all the world to me like an operating room. It's got everything an operating room would need, right?
It does. Should patients come in and require blood transfusions, we have all of that stocked and ready. That is our cabinet that has pretty much everything you could possibly conceive of for any kind of emergent circumstances. We would be able to treat based off of the supplies that we have ready for us in the trauma bay.
So what were the 6 patients you saw today? No names.
Of course. We saw 2 ground level falls in patients who ended up actually being a little bit sick. One of those patients required several hours of my time because she ultimately ended up in the intensive care unit, was unstable. And then we've seen, I'm going to say 3 or 4 car accidents today. So
wow.
I'm not sure why. Maybe it's a Monday thing.
And the weather was good. It wasn't like there was
know.
ice or anything like that going on. But a lot of just car wrecks and as we sit here, it's a Monday.
Exactly.
That's unusual, isn't it?
It is unusual. We typically will see weekends, Friday and Saturday night. Full moons
I was
are
going to say,
always busy.
that is true, isn't it?
It is very true.
Full moons do
See, I thought
bring
that would
out.
just be a story. I didn't
No.
think that was
No,
really.
full moons are absolutely true, and especially for penetrating violence. So for assaults and gunshot wounds and stab wounds, usually the weekends, and then when the seasons get nice, people go out and stir up trouble every once in a while. So.
How do you determine? Okay, you're the surgeon. How do you make a call that surgery is necessary?
So the nice thing about trauma surgery is that it's all very protocolized. So we go through and look at, does the patient have life or limb-threatening injuries? If those are present, usually those patients need to be in the operating room in less than a half an hour or so. And then we go through and have very nice evidence-based protocols. So if a patient has this type of a spleen injury, that means they need to go to the operating room. If they have a lesser grade of an injury, then we can monitor that patient on the floor as opposed to taking them straight to the operating room. So that's the nice thing about trauma surgery for us is whether it's nights or weekends, 365, 24/7, the thought process and the algorithm that goes into our decision making is generally speaking the same.
And in most cases, unless you just have a flurry of people needing the operating room at the same time, the operating room is right there at the ED, right? So you can get them right in there, just almost within moments.
We can. It's a short elevator ride up from the first floor to the 3rd floor, and we're right there. So
Now I noticed that we had the CAT scanner in the emergency room. In the bad old days, without a CAT scan, you would have to guess in a sense that the patient had some bad injury. Sometimes people would even have little operations just to determine whether they were bleeding internally. How has the CAT scan kind of revolutionized trauma surgery?
That's a great question. It's allowed us to make decisions where we don't have to go to the operating room to look and see. We have the opportunity, if the patient is stable, so if their vital signs are stable and they're doing okay, where we can go to the CAT scanner and get much more information, get a better roadmap should we need to go to the operating room down the road. But it just allows us to get much better visualization of what we're looking at as far as how do we need to treat the patient.
And literally, you could scan somebody from the tip of their head all the way to their toes and determine if they had intracranial injuries, chest injuries, abdominal injuries, broken bones.
Absolutely. And it's really the best way now for us to visualize what's going on as far as, does the patient have bleeding or bruising in their brain? Do they have chest injuries? Do they have abdominal injuries? Really the far superior way, as opposed to doing an operation or putting a camera in the operating room, is to go get a CAT scan. It really has revolutionized the way that we do things.
The chain of events, once you determine that a person needs to go into the trauma room for surgery, is that person likely to stay there, or does he or she go to intensive care right away, or how does that happen?
The vast majority of patients who go to the operating room emergently after a trauma will end up going to our trauma intensive care unit, which is...
Oh, there is a separate intensive care unit for trauma.
There is.
Oh, okay.
Much like my colleagues have their own cardiac ICU, we have a beautiful 6-bed trauma ICU.
They have the nicest one.
It's newer, isn't it?
It is.
We've
We'll
got
change that, but for the time being, it is. She does have the nicest one.
We have fantastic staff up there. We have trauma nurses that are trained specifically in the critical care of trauma patients. And we have our own 6-bed ICU that is designated for trauma and surgical patients. So we very much are able to focus on those kinds of injuries and the types of issues that are unique and specific to my patient population.
You know, and Dr. Mishkel, I know you're familiar with it. The trauma history in Springfield has been very interesting with the two hospitals.
Very much so.
And, you know, there were years where they were alternated, you know, one was trauma 1, trauma 1. Now both are trauma 1 level hospitals, I think. Isn't that true?
We are.
Yeah,
That's
okay.
true.
And plus you have the pediatric trauma abilities too.
Yes. The unique thing about our program, which I think is really a blessing and a gift, is we have a children's hospital. We have a state pediatric level 2 trauma designation. So the nice thing about that is when patients, God forbid, if families are involved in car accidents, instead of taking the children to one hospital and the adult patients, the parents, to another hospital, the entire family is able to be cared for in the same facility. They're able to see each other and maintain contact through their treatment. So I think that's one of the strengths of our program that makes us unique in Springfield. And it's something that we're very proud of. We worked very hard. I personally think we take excellent care of children. But definitely of the entire family as well.
So let me ask you just a quick question. I've heard of this golden hour. Is that something that still exists? And what does that mean?
It is. So what it means essentially is if a patient has a car accident, shooting, stabbing, some kind of a traumatic injury, usually we have about an hour to get that patient to go one way or the other. So if we can get to that patient and initiate really good trauma treatment, so resuscitation, potentially some kind of an intervention or operation within an hour, the likelihood of that patient surviving goes up significantly. That was at least the traditional teaching. I think what we've seen is really it's more like minutes. We want to get to patients as quickly as we possibly can. And so obviously we want to transport patients into trauma centers as quickly as we can. But the traditional historical teaching has been the golden hour of trauma, in the sense that we've got about an hour to intervene before we lose our window.
Well, you know, we were talking to Dr. Alepra about the emergency department doctors and nurses, and she said, no, they're not on call because they need to be right there. Is that the same way with trauma surgeons? I mean, if you've got that amount of time, you've got to staff it. You can't be saying, okay, let's page so-and-so. They're
exactly.
there. Huh?
So the beautiful thing about my program is that we have a board-certified or board-eligible trauma surgeon in-house 24/7. That's also one of the unique facets of our program in the Springfield area. So we have an actual attending surgeon in-house 24/7. So God forbid, whatever it is that comes in, we are 100% always ready for it. regardless. So,
Now you were trained as a surgeon.
yes.
What made you want to do trauma surgery?
She likes staying up at night.
I mean, really. I mean, why would? I mean, if you could be a general surgeon and you could just, your patients could choose the times they knew 3 days in advance. Why would you want to be trauma? I mean, that's tough.
That's a great question. I am a little bit of an adrenaline junkie, I'll admit it. But I think that the trauma surgeons, of all of the surgeons that I worked with, were the folks that were the most personable, the most logical, rational, and really the people who were calmest in a storm. And that was something that I think I probably got from my father, who's also in medicine. But it really was a passion of mine. How calm can you make the room? Can you be the captain of the ship in a very calm, controlled way when there's absolute chaos going on? When patients are just sick as can be, can you be calm and still be a leader and still make sure that the patients get exactly what they need? And so that for me was a passion and a challenge. But I also just was attracted to the personalities. They seem to have a great sense of humor, trauma surgeons, and an ability to, we see absolute tragedy, and then we're able to bounce back immediately, and the next patient needs my focus. And so that kind of variability and the ability to be flexible 24/7 is something that I really love. It's a great challenge, and it I think brings out the best in people who are meant to do trauma. So.
Maybe in another lifetime. That's not me, though. It's interesting. That's an interesting comparison you made, though. It is like piloting a ship or an airplane, because not only do you have to have the ability to do that particular job, but you're also the commander. And the whole tone of the room. You
can never show any fear.
The whole tone of the room is going to depend on how you're handling the situation.
Yeah, and I think that's something learned from experience and watching. My mentors are military trauma surgeons. Military trauma surgeons in the U.S. military are the best in the world, and they see horrible injuries in young men who are serving our country, and just cool as cucumbers. They have seen everything. They have no fear, and that was the way that I was trained. So I'm just hugely grateful to have been able to work with people who are the best of the best at what we do.
Almost makes you want to drive recklessly.
Just to get
Let's
a chance
hope
to
not.
see it in action.
Right.
Gosh, texting and driving is the bane of my existence now. Holy
That's actually a
cow.
very good point.
It is. It's a very good point.
It's scary.
I wish we had time to go ahead and pursue that, but we don't. We've run out of time. But Doctor, thank you so much. Dr. Jerge, thank you so much for coming in.
Thank you. Thank you guys for having me.
Thank you, Carrie.
And Dr. Mishkel, thank you. And thank you always for watching. Remember our motto here, the heart. Everyone has one, and the more you know about it, the better you can care for it. We'll see you next time.